Good evening, everybody. I just opened the meeting room here, the virtual meeting room, and we'll just take a brief moment here to let everyone come in and get situated. We'll start here briefly. Before we start, I'll just encourage everyone to go to the AAPS website. We have several new postings there this week that you'll want to see. One is an action alert that's relevant to our discussion tonight. And there's also some new articles about other things we're doing about our lawsuit against the FDA. So please be sure to go to the website. We have we're really grateful for everybody joining us tonight. Wow, we've got a really strong attendance tonight too. This is a really hot topic. So, all right, it looks like it's time to go ahead and I'll formally kick things off here. Good evening and welcome to tonight's webinar hosted by the Association of American Physicians and Surgeons. My name is Jeremy Snavely and I'm the business manager for AAPS. As I said, we're grateful to have everybody with us tonight. Just a few brief housekeeping items. We are offering an hour and a half of CME credit, and so we need to let you know that neither the presenter nor the organizers disclosed a relevant financial interest related to this topic. And as always, claiming your CME credit will require filling out a post-event evaluation that we will email to everybody about 30 minutes after we finish tonight. And be thinking of your questions. We'll have plenty of time for Q&A and discussion following the presentation. And you can either type in your question in the Q&A box, or if you'd like to ask it verbally, raise your hand using those buttons. And so with that, I'll go ahead and turn the webinar over to our immediate past president, Marilyn Singleton, MD, JD, who's helping us tonight. Dr. Emmons, who normally helps kick things off, is unable to join us tonight. He'll be back next time. But we're grateful to Dr. Singleton for helping out tonight. And so with that, I'll turn it over to you, Dr. Singleton. Thank you very much.
Well, thank you, Jeremy. You're our business manager and so much more. So I am just pleased as punch, as they say. Naturally, my dog started barking just when it was my turn to talk, to present my years-long pen pal, Dr. Rebecca Bernard. We've been writing and emailing, and we've never met face-to-face. So this is about as close as we'll get right now. And I know everyone will enjoy this talk. Rebecca has written 2 prior books, and one is called Physician Wellness, The Rockstar Doctor's Guide, and the other, How to Be a Rock Star. So this book that we're going to be discussing tonight, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, will be very revealing and a bit different from her prior work. Dr. Bernard's from Florida, and she's the daughter of 2 registered nurses, lest you think that this is some sort of attack on nurses, that this whole topic is really something to keep medicine great. She's in Florida, has a direct primary care practice, and she opened this. One thing that so impressed me about her biography is that after her residency, she went into the National Health Service and worked in a rural town. And this is somebody who puts their money where their mouth is. And I really respect that. And to me, it's probably one of the most impressive things, books aside, for folks to go out in the rural areas and really work. And I just find this so important because one of the arguments for nurse practitioners is they're the ones that are going to go out in the country. And that isn't necessarily so. But I'm not going to take away everything Doctor has to say. And with that, take it away, Rebecca.
Thank you so much, Dr. Singleton, and thank you, Jeremy, for inviting me to speak on this very important topic, and one that unfortunately many physicians don't know too much about, much less patients. The title of the presentation is Patients at Risk, the Rise of the Nurse Practitioner and Physician Assistant in Healthcare. It's based on content from my book that I co-wrote with Nuran Al-Ajba, pediatrician, and the book is going to be published shortly by Universal Publishers. I'm a board member of an organization called Physicians for Patient Protection. It's a grassroots organization of physicians and medical students with one mission: to ensure physician-led care for all patients and to advocate for truth and transparency regarding healthcare practitioners. I'd like to start off by introducing you to a young woman by the name of Alexis Ochoa. Alexis was 19 years old, a college sophomore, and an athlete when one day she suddenly developed acute symptoms of shortness of breath and chest pain, and she fainted. Her boyfriend was alarmed. He called 911. An ambulance came and picked up Alexis and drove her to the local emergency room in her town of El Reno, Oklahoma. This was on the afternoon of September 27th, 2015. When Alexis arrived, she was unstable, her blood pressure was low, her heart rate was elevated, and her oxygen levels were low. The paramedic even suspected that Alexis was having a pulmonary embolism or a blood clot in the lungs. When Alexis arrived at the emergency room, she was greeted by a family nurse practitioner by the name of Antoinette Thompson. Thompson had been certified as a nurse practitioner about 9 months prior, and her first job as a nurse practitioner was working in the emergency room there at Mercy El Reno. She did have clinical experience. She had worked for many years as a firefighter, paramedic, and an emergency room nurse before she went back to school. She completed an online nurse practitioner training program through the University of Southern Alabama. That was 100% online, other than 2 weeks that she attended on campus. In addition, she was required to complete 500 clinical hours, as are all nurse practitioners, and she completed those hours providing prenatal care to low-risk women at a county health department. So her certification was as a family nurse practitioner, yet Antoinette Thompson was hired to work in an acute care setting in an emergency department. Thompson was hired by an organization called Mercy Health Systems. Mercy at the time was one of the top 5 large health systems in the South of the United States, a multi-billion-dollar corporation. The hospital system employed 2,400 doctors and owned 400 hospitals. The hospital also had the habit of hiring and credentialing nurse practitioners to work in their facilities, including family nurse practitioners to work in acute care roles. Even though the bylaws at the hospital and the Oklahoma Nurse Practice Act stated that nurse practitioners should have acute care certification to work in those settings, nonetheless, the hospital decided to go ahead and credential a family nurse practitioner to take on that role. Not only that, they allowed nurse practitioners to work independently without on-site physician supervision. So on the day that Alexis Ochoa arrived, Thompson was there by herself working. What's really interesting is that the Mercy Health Systems on their website had listed very prominently that the emergency room was staffed 24/7 with physicians to market their hospital to patients. However, this was not often the case, and on this day, it was not true at all. Unfortunately, one problem after another began as Thompson began to evaluate her patient. Almost immediately, the nurse practitioner got distracted by a test result that came back showing that Alexis had methamphetamine in her system. The patient denied the use of drugs, and she had no other symptoms to suggest this, and more importantly, she had symptoms to suggest an alternate diagnosis. However, the nurse practitioner got distracted and began to direct her care at treating this presumption of methamphetamine. She treated Alexis for 11 hours, and during that time, the nurse practitioner never once contacted her supervising physician. At last, she finally decided to transfer the patient to a tertiary care center, and when Alexis arrived, she was correctly diagnosed with a pulmonary embolism, but it was too late. Within just a short period of time of arrival, Alexis Ochoa died. Alexis's family filed a wrongful death suit against Mercy, and they won $6.19 million. Unfortunately, things at Mercy didn't really change much. None of the people that were involved in the hiring of Thompson were punished or lost their jobs. In fact, several of the administrators were promoted. And what happened to Ms. Thompson Well, she quietly moved away from Oklahoma and moved to Iowa, where she began working. And as of most recent information on their website, she's working at the Veterans Memorial Hospital in Iowa. If you go to their website, you'll see her name listed as a provider in the emergency room. And what's interesting is you won't see the names of any physicians listed as emergency room practitioners, only nurse practitioners and physician assistants. Of course, the Veterans Administration allows nurse practitioners to treat patients independently, as does the state of Iowa. It took 5 years from the death of Alexis Ochoa and a year from the lawsuit before the Oklahoma Board of Nursing finally sanctioned Antoinette Thompson. Just about 6 weeks ago, they actually sent an order of suspension for 1 year. She was ordered to pay a $1,000 fine and to complete continuing education. How have we gotten to a point in which nurse practitioners are legally permitted to take care of extremely ill patients in an unsupervised fashion? Let's look at the development of the role of the nurse practitioner and how it even came about. The first nursing program in the United States was formed in 1872, and it was created by a woman physician by the name of Susan Demock. Interestingly, Dr. Demock had applied to Harvard Medical School, but she was rejected because they were not accepting women applicants at the time. So instead, Demock went to the University of Zurich in Switzerland and received her medical degree. She returned to the United States and opened a training program for nurses in Boston. The nursing profession rapidly grew, especially as hospitals increased at the turn of the century. Also, as more people moved into inner cities and public health nursing became very important, the profession grew more, especially to treat patients with communicable diseases like tuberculosis, and then with the Spanish flu pandemic of 1918. In the 1950s, nurses moved out of the hospitals and began to do training in the universities. And it was in 1964 that the first nurse practitioner program opened. Dr. Henry Silver, a pediatrician, co-founded the first nurse practitioner program with a nurse by the name of Loretta Ford. The idea of these nurse practitioners was that they would be focusing on well child care, and they would be providing care in areas of physician shortages. Within just 9 years from that first program, there became 65 nurse practitioner programs, and the profession really flourished. In the 1970s, the government decided that one strategy for mitigating the physician shortage would be to study an extended role for nurses in providing care. And they encouraged that by things like the 1977 Rural Health Care Act, which required that any rural health center that received federal funding had to staff the facility with at least 50% nurse practitioners and physician assistants. Over time, nurse practitioners fought for provider status, and they began to gain the right to be directly paid by Medicare rather than being paid through an association with a hospital or a physician. In the 1980s, nurse practitioners really began to fight for what they call full practice authority or independent practice. And they really began focusing on the rural states, which had more underserved patients. They've been very successful in this. In 2019, as you can see on this map, almost half of the states in the union had granted nurse practitioners the right to care for patients independently. I've crossed out Florida because in 2019, nurse practitioners were granted legislatively the right to provide primary care. California has a big question mark, although the bill just passed to grant nurse practitioner independent practice and is awaiting Governor Newsom's signature. And Virginia now allows independent practice. One of the reasons that we've seen such a growth in nurse practitioners has to do with some important things that happened in 2010. The Institute of Medicine produced something called the Future of Nursing Report, and it was very influential. It was a white paper that called for a dramatic increase in nurse practitioners, especially nurses with a doctorate degree. And ultimately, the paper asked that nurse practitioners be given full partnership with physicians. That same year, the Affordable Care Act expanded nurse practitioner training programs and gave a lot of money to increase the training of nurse practitioners, while not really significantly increasing physician funding for residencies, which have been frozen since 1997. The act also created nurse-led community health centers. So as a result of that increase in funding, we've seen a dramatic increase in graduates from nurse practitioner training programs. There's been an almost 200% increase from the year 2010 to 2019. How have nurse practitioners been so influential in making these advances? Well, they've been excellent at cooperating, which is something that doctors we sometimes struggle with, but nurse practitioners have really been strategic at cooperating. In 1993, they gathered many different groups of nurse practitioners. They came together in a coalition and they had one mission, which was to advocate for direct reimbursement for services. That was very successful. They've also utilized political advocacy extremely effectively and been able to gain legislative support for what they see as the best use of their services. And they've also worked very closely with organizations that have given them very good amounts of funding, especially the Robert Wood Johnson Foundation. You've heard of Johnson & Johnson. They're the largest manufacturer of household items and one of the largest manufacturers of medications. Robert Wood Johnson was the founder of Johnson & Johnson, and he created a foundation in 1972. That is now the largest U.S. health-focused philanthropic organization, reporting $11 billion in assets. This organization has donated $674 million since it began to promote the work of nurses. One of their most important projects has been the creation of the Executive Nurse Health Fellowship Program. They've given $41 million over the last 20 years. And this is a very special fellowship program that takes nurses that apply and puts them in positions to be very closely acquainted with legislators and policymakers. It gives them a seat at the table so that they can work, as they say in the fellowship advertisement, the nurses work, quote, side by side with legislators to craft healthcare policies. So these have been instrumental opportunities for nurses to gain political experience and develop advocacy. The Robert Wood Johnson Foundation also subsidized the Institute of Medicine's Future of Nursing report. And they actually sponsored and paid for the report, the one that called for an increase in nurse practitioners. The foundation then donated millions and millions of dollars to the AARP to help implement recommendations from the report, including state action plans in which each state advocates for legislative changes to increase nurse practitioners. And then they also donate millions of dollars towards efforts to educate the public about nursing. They call it new health areas. They donated about $8 million, for example, to National Public Radio for healthcare reporting. Why does the Robert Wood Johnson Foundation have such a strong interest in supporting nurse practitioner independence? It's really unclear, but of course we know that, as I mentioned, Johnson & Johnson being a large drug manufacturer, for example, Janssen Pharmaceuticals is a subsidiary of Johnson & Johnson. They are the makers of many medications, including opiates. The Robert Wood Johnson has a very close relationship with CVS, which of course is a drugstore chain that sells their products. And Minute Clinics are a big part of CVS. Minute Clinics are healthcare clinics that hire almost exclusively nurse practitioners. And I'll show you later that nurse practitioners, as well as physician assistants, have a much higher rate of prescriptions of medications, including opiates and other drugs. And then finally, Robert Wood Johnson Foundation has a strong relationship with the AARP, paying them millions of dollars to advocate for what they would like to see happen. And the AARP also sells Medicare supplemental policies to senior citizens, most particularly those provided by United Healthcare, which owns Optum RX, a pharmacy benefit manager that manages prescription medications, again, probably prescriptions of medications that are produced by Johnson & Johnson. So there's a lot of circular relationships. The exact reason behind why they support nurses so much is not fully clear. Physician assistants started around the same time as nurse practitioners in 1965. Eugene Sneed was the first physician to create a physician assistant program at Duke University. And his idea was to take military corpsmen that were returning from the Vietnam War and to give them extra training to build on what they had learned in the military so that they could provide primary care. Henry Silver, the same doctor that started a nurse practitioner program, the first one, he also created a physician assistant program at the University of Colorado. He called these people, they were women, he called them child care associates. And the idea was that, again, they would provide well child care, preventative care, and work in underserved areas. Because of a physician shortage that was predicted in the 1970s, federal funding began to try to compensate for a physician shortage by training physician assistants to work in primary care and underserved areas. Most recently, one of the biggest changes that we're seeing in physician assistants is a transition from the traditional model of care, which has been one physician assistant working under the direct supervision of one physician. Instead, the American Association of Physician Assistants has changed their model to something that they call optimum team practice. And that allows physician assistants more autonomy, the ability to work under multiple physicians or an umbrella organization, and in some cases, the ability to practice autonomously. And one of the ways that they've sought to increase their autonomy is by changing their name. It's kind of hard to be independent when you're calling yourself an assistant. So the American Association of Physician Assistants hired a research company to try to strategize on a way to change their name. And they had suggestions like changing it to physician associate, but ultimately they seem to have settled on just using the acronym PA. And they've advised people, their members, if someone asks you what PA means, then you just tell them that you are a medical practitioner. So this is what we're seeing, and it's worked well for them already. Just last year, physician assistants won independent practice in the first state of South Dakota. And this year, because of COVID-19, several states have relaxed practice restrictions on physician assistants and have allowed independent practice. Right now, we're also seeing physician assistants calling for that temporary relaxation to be made permanent. And while nurse practitioners have nearly doubled, physician assistants have grown by about 60% between 2010 and 2019. So also growing at a nice rate. Let's take a look at the difference in training and education between the three professions. Nurse practitioners typically receive a 4-year bachelor's in nursing degree before they go on to nurse practitioner school, although there are programs now that are offering a direct entry program for non-nurses. And what that means is that you can have a bachelor's degree in any subject, economics, business, art, and then go on to develop a nursing degree along with your nurse practitioner degree at the same time. So there are nurse practitioners that are graduating today that have not worked even a day as a nurse prior to becoming a nurse practitioner. Some nurses first develop an associate's degree or a registered nursing degree. They then work for a while and maybe attend classes part-time to get their bachelor's degree and then go on to nurse practitioner training. There are many flexible options for nurses. There are part-time programs. There are accelerated programs. There are even programs that allow bachelor's degree nurses to become a nurse practitioner in about 12 to 15 months' time. Physician assistants typically spend 4 years in an undergraduate program. Their PA school is 2 to 2.5 years for a master's, although there are some new doctorate level programs for physician assistants. Physicians, of course, do a 4 years of college, 4 years of medical school, and then one of the biggest differences between the professions is that physicians are required to complete a residency period of training. In every state, it's at least 1 year, but most states require 3 years. And for any foreign medical graduates, they must complete at least 3 years of residency before they receive a medical license and can care for patients independently. When you break that down by hourly clinical experience, nurse practitioners are required to complete 500 clinical hours before they can sit for their nurse practitioner examination. For a doctorate in nursing practice, those clinical hours must be at least 1,500. Physician assistants receive about 2,000 hours. Physicians, it's estimated, get 6,000 hours just in medical school and about another 10,000 hours in residency at a minimum. So the average physician is starting independent practice with at least 15,000 hours of experience, if not more. Just for comparison, to see what some other professions require for minimums, to become a barber and cut hair, you need 1,800 hours of practice cutting hair. To be a massage therapist, you need 750 hours. And just to apply someone's makeup, you need 600 hours of experience. Even a PetSmart's dog's groomer requires 800 hours of training and experience before they're permitted to cut a pet's hair. And why is that important? Well, really, we know that experience and training does matter. It's estimated that it takes at least 10,000 hours to gain mastery or expertise in any field of study. That's been shown in mathematics, in chess, in long distance running. That 10,000 hours really seems to be the minimum that we need. When we have less than that, we fall victim to a problem of not knowing what we don't know, or something that has been described by a psychologist as Dunning-Kruger effect. Dr. David Dunning and Justin Kruger were psychologists that noticed that some people really had poorer ability to gauge their own competence in a certain area. And what they discovered through experimentation is that for some people, the less they know about a subject, the higher their level of confidence. And what they showed was a curve that happens as a person gains experience. They actually have a decrease in their confidence because they realize how much they don't know, how much they still need to learn. Most physicians are familiar with this by something we call imposter syndrome. It usually happens about halfway through medical training when we've reached that lowest point of our confidence and we really start to feel like we're never going to know what we need to know. But gradually over time, as we continue to gain expertise, that confidence slowly increases, although it never gets quite up to the level of confidence that we had before we knew anything about a subject. So this is really important because what happens is that people that don't have the experience or the knowledge overestimate their confidence, and that is often when they get into trouble. Nurse practitioner organizations have been working very hard to gain what they call full practice authority, and they define this as an authorization for nurse practitioners to evaluate patients, diagnose, order and interpret diagnostic tests, and initiate and manage treatments, including medications, under the exclusive licensure of their state board of nursing. And they've justified this autonomous practice by arguing that allowing independent nurse practitioners will increase patient access, it will streamline care and make it more efficient, that nurse practitioners will decrease costs, and that this allows patients to have a choice. So are any of these arguments true? Well, first of all, we know that nurse practitioners do not practice more in rural areas than primary care physicians. In fact, family doctors are the most likely of any specialty or any profession to work in a rural area. 77% of all nurse practitioners practice in cities or suburbs. Only under a quarter practice in rural areas. And what's very interesting are the states that have granted independent practice have not seen a mass exodus of nurses into these rural and underserved areas. The American Medical Association has produced a series of maps of each state where they've actually shown the location of primary care physicians and the location of nurse practitioners so that you can see what the distribution looks like. I've selected Washington as an example because it's one of the first states to gain nurse practitioner independence, and it also is a state that has a large rural area. And you see here the purple circle are primary care physicians, the blue triangle are nurse practitioners, and you can see that there is a significant overlap of the two. And if you are looking for isolated rural areas, you'll see more of the physicians located in those areas than you will see nurse practitioners. And that just holds true for every state that you look at. One of the really important statements that nurse practitioner advocates will state is that nurse practitioner care is safe and effective, and that they have 5 decades of research to prove this to be the case. So the question is that true? And what do these studies actually show? Well, Cochrane, which is a database that does meta-analysis and examines studies, produced a report called Nurses as Substitutes for Doctors in Primary Care in 2018. Cochrane examined every single study and research that has been done on nurse practitioners since they were first developed in 1965. Of all of the hundreds and hundreds of studies that have been done, only 18 of those studies were selected for review because they met the criteria. Of those 18 studies, only 3 of them were performed in the United States. And I'm going to talk about some of the other challenges that we found in these studies. But first, let's look at the conclusions from the authors, because it sounds pretty good from the standpoint of nurse practitioners. If I were a legislator reading this, I would agree. It sounds pretty good. It says here that this review shows that for some ongoing and urgent physical complaints and for chronic conditions, trained nurses probably provide equal or possibly even better quality of care compared to primary care doctors, and probably achieve equal or better health outcomes for patients. Wow, that sounds really great. But what did these studies actually examine, and what were some of the flaws? Again, as I mentioned, there were only 3 studies that were performed in the United States that were included in this study. The most important and the best scientific study that has ever been done on nurse practitioners in the United States was completed by Hamani in 1999. Nurse practitioners in this study were supervised by physicians 100%. This study involved 450 patients at the Baltimore VA, and the ultimate final conclusion was that in a primary care setting, nurse practitioners may utilize more healthcare resources than physicians. They utilized more resources than medical residents, more than attending physicians. They ordered more lab tests. They ordered more imaging studies, and hospitalization rates were higher for nurse practitioner patients, even though their patients were of lower acuity. The second study, completed in the United States, was done by Mary Mundinger in 2000. You hear this study often cited in the literature on nurse practitioners. What was happening in the study? 17 physicians and 7 nurse practitioners were compared in a community outpatient primary care setting. There were 1,300 patients. They were low-income, transient Hispanic women, and they were followed for a period of 6 months. Physicians were always available for consultation, as New York was not an independent practice state at the time of the study. The summary was that after 6 months, there was no difference in health status or health service utilization amongst these low-risk women. And nurses provided more education, they ordered more laboratory tests, and they did not refer any more frequently. However, this study was also noted, according to the Cochrane reviewers, that it had the highest amount of bias of all 18 studies that they reviewed, because subjects were not randomized, there was no blinding done, and only favorable data was reported by the study authors. 1967, Lewis studied 66 patients, mostly women with 1 chronic health condition. All the nurse practitioners were supervised, and there was only really one question that the study was designed to answer, which was, would patients be willing to see a nurse practitioner? And the answer was yes. Those are the only single studies done in the United States included in this Cochrane review. The rest of the studies, most of them were in the United Kingdom. And in the United Kingdom, nurse practitioners are 100% supervised. They do not practice independently at the time of any of these studies. 2 of the studies were simply involving telephone triage advice, and found that experienced nurses could safely provide telephone triage advice using protocols and software guides. Schum in 2000 did a study of 790 patients. They evaluated minor medical complaints, and they excluded high-risk patients. And they found that of these patients, over a quarter required physician evaluation. And ultimately, researchers stated that they could not draw conclusions because the study was not large enough. Denning in 2000 examined 1,300 walk-in patients that were followed over 2 weeks. Nurse practitioners always had access to a physician, and they required assistance 17% of the time. The study was designed to evaluate the cost effectiveness of nurse practitioners, and found that nurse practitioners spent more time with patients, performed more tests, and had more frequent follow-up visits, but was not powered adequately to determine whether or not they were cost-effective. Mower in 2001 designed a study to assess the prevention of heart attacks and strokes by following 3 risk factors. Nurse practitioners were supervised and they followed protocols, and they were able to provide excellent quality of care following protocols. However, it was noted that following up on these 3 risk factors did not actually equate into fewer heart attacks or strokes. There were several specialty care trials in the UK, one with a rheumatology clinic. Supervised nurse practitioners following protocols in chronic disease were cost effective. A gastroenterology clinic in which nurse practitioners followed up on patients after endoscopy, high-risk patients were excluded, and they found that that was something that nurse practitioners were very qualified to do. The next set of studies were done in the Netherlands, where nurse practitioners are 100% supervised. One involved first contact primary care, and the conclusion was that it was inadequately powered to determine the safety. Howling in 2011 examined non-insulin requiring diabetic patients, 100% supervised, found that nurse practitioners referred more often and spent longer with patients, but that the sample was not adequate to assess their quality of care. In a 2010 study in which patients at risk for coronary artery disease were evaluated and high-risk patients were excluded, and nurse practitioner patients did have an improvement in their risk reduction when they followed physician-created protocols. 2 really important studies were done in Canada at the very early onset of nurse practitioner role. One of the first was done by Spitzer, and that's called the Burlington Study in 1974. 2 family physicians and 2 nurse practitioners worked side by side, and they found that working together, physicians and nurse practitioners could provide excellent care, and that nurse practitioners were as safe and effective as a physician 55 to 67% of the time. Chambers in 1978 also did a 100% supervised study showing that nurse practitioners supervised could provide quality care. In a few other countries, South Africa showed that nurses that were supervised could monitor HIV therapy. In Sweden, nurse practitioners were able to monitor stable patients with chronic inflammatory arthritis. In an important study in Spain in 2003, nurse practitioners evaluated patients with minor complaints. They were able to manage most cases of burns, injuries, and diarrhea independently, but they were not able to manage independently most cases of low back pain, colds, or urinary symptoms. So in summary, although the headline looked really good, there are a few really important caveats. First of all, every single study that was examined by the Cochrane database involved 100% physician supervision. Almost every study excluded high-risk or chronic complex patients. Most of these studies, as you saw, were very small in sample size, patient populations were not very diverse, and there was a very short-term follow-up. So there are many flaws to the argument of 5 decades of research showing safety and efficacy. Certainly, this does not speak to independent practice in any way. The Veterans Administration also performed a meta-analysis in 2014. They utilized most of the same studies that were reviewed in Cochrane and a few additional ones involving CRNA or anesthesiology, nurse anesthetists. And the headlines were, there was no difference between nurse practitioners and physicians in health status, quality of life, mortality, etc. However, if you look at the strength of the evidence, you'll see that the evidence is insufficient, low, at best medium, and that there was a high risk of bias. So even though the VA acknowledged that there was inadequate evidence to show safety and efficacy, they still made the decision to allow nurse practitioners to practice independently on veterans. The question is often, well, isn't some care better than no care? We still need access. And that sounds pretty convincing, but the truth is that it's wrong. A study published by The Lancet in 2018 showed that worldwide, more people die every year from poor quality health care than those who die from a lack of access to care. And this was not examining the United States, it was looking at more at developing nations. But the authors of the study said that really this is of deep concern, and that it's better, instead of focusing on just increasing access, What is most important is that we focus on quality access. And it's important because we're finding that many nurse practitioners they don't rate themselves as being competent in clinical practice in many areas. This was a study in which nurses were asked to self-assess their competencies. And they asked associate's level, bachelor's degree level nurses, but also nurse practitioners, which are you'll see the green diamond there. And you'll see that nurse practitioners in all but one rated themselves as needing improvement in all areas of clinical competency. So even nurse practitioners themselves are acknowledging concerns. We know from studies that compared with physicians, nurse practitioners and physician assistants order more laboratory and radiology tests. They perform more unnecessary skin biopsies. They prescribe more medication, including unnecessary antibiotics, psychotropics, and opioids. And their referrals to specialists are not of the top quality in many cases. And it's becoming even more concerning because, as you saw with the growth of nurse practitioner training funding, we've seen an explosion of nurse practitioner programs, and many of which are called by some people diploma mills, because they'll admit any warm body. This is a list of 9 nurse practitioner programs that have a near 100% acceptance rate, so anyone that applies is automatically accepted. As I mentioned, there are direct entry programs for non-nurses. There are many, many online programs and so many different routes to becoming a nurse practitioner. And nurse practitioner students are even speaking out about these programs. Here's a recent graduate from a direct entry program who was discussing his experience on social media. He told everyone that he was a psychology major. He had never worked as a nurse. He went to a direct entry program, and then here it says orientation training for the next 2 weeks, and then I'm all on my own in my primary care clinic. And now, without a day of nursing, he is now providing care to patients at a minute clinic. Just to let you know that physician assistant schools are also getting in on the bandwagon of online training. Yale was the first program to graduate an online class, but other PA schools are following their lead. There's a lot of money that is being made in these programs. I believe the last time I checked, the Yale online program, the tuition was about $100,000. So, and there's a demand for this. So there's more and more reason for these programs to continue to try to seek out students. And as I mentioned, nurses and some PAs too are expressing concern about programs that are not providing the quality education. This is a social media post from a past president of the American Association of Nurse Practitioners, who says that she personally thinks that those who teach in those programs should be embarrassed and ashamed, but they choose to follow the almighty dollar. And she says that the AANP really sometimes doesn't have recourse to help stop this. And her argument, she believes that schools need to increase their admission criteria, that nurses should have nursing experience. So even former leaders of the organization are concerned about it, but very little is being done as of right now. Well, one of the things that is being done is that nurse practitioner leaders are speaking out about nurse practitioners and students being a little more cautious about showing the public that they may need a little extra help in training. Here are a couple of posts. I could pick from hundreds of them from nurse practitioner online groups where they go onto social media and try to get help to learn because they're not getting the adequate learning in their program. The first one is a nurse practitioner 3 weeks into seeing patients and realizing that they don't know how to deal with abnormal labs. Is there a book to use to learn how to do that? Another one that just found out that they'll be seeing pediatric patients. Can they get some helpful hints with pediatrics? As a family doctor, that strikes terror into my heart because I still, 18 years later, I'm always a little nervous when I see children just in case something goes wrong. And the last one, a primary care nurse practitioner for a year who did not get much practice on PAPs and pelvic exams and wants to know if anyone has any tips on how to help locate the cervix. That's something, of course, that should have been taught in training and not a patient just getting practiced on in the real world. So as you see on the right, the current AANP president actually was concerned enough about this that she went to write about it, asking nurse practitioners, please don't go on these online forums and make these discussions because anti-NP people are using this against us. You know, is that the biggest concern, or should the biggest concern be that the practitioners need help? They need to get the proper training before they're being encouraged to treat patients, and especially to treat patients without physician supervision. You know, the truth is that patients don't know the difference in many cases. It's confusing. There are 183 different nursing certifications, and we've all seen the string of alphabet soup behind some people's names, and you don't know, if I don't know what that means, how does the average person know? Of course, there's the confusion with doctorate degrees. It's doctor, nurse. For example, on the right, they talk about there's a new doctorate in physician assistant training, and it's called the Doctor of Medical Science. And so here's a headline that misidentifies a physician assistant as a medical student and a doctor when they're actually a physician assistant. So of course this is confusing. And then it's further confused by the fact that we are seeing appropriation of terms that are traditionally used by physicians, like board certified. You know, I'm no longer board certified by the American Board of Medical Specialties. I dropped it and I now use the National Board of Physicians and Surgeons. I did, of course, board certify initially and I recertified, but the third time I decided I didn't want to spend the money and I didn't want to do the maintenance and certification. I'm not legally allowed to advertise myself as board certified in family medicine, even though I've certified twice. But yet I see nurse practitioners calling themselves board certified in all sorts of different types of practice. They're also using the terms residency and fellowship, but they're not talking about the same type of programs that physicians go through. A lot of times they're 40-hour work weeks or even weekend courses that are being termed fellowship. So this has got to be confusing to patients. And of course, it doesn't help that patients are receiving direct marketing. There's a big campaign by nurse practitioners called We Choose NPs. And if you go to that website, you'll see their claims that nurse practitioners provide greater patient satisfaction. They actually link to a study that had 98 patients that reported preferring nurse practitioner. PAs also are marketing directly to patients. They have a slogan now that's called Your PA Can. Your PA can handle it, encouraging the public that, you know, to have confidence in non-physician practitioners just as much as physicians. And it doesn't help when these practitioners call themselves specialists. And in some cases, they're being hired by a physician and working under them, but in other cases, they're really just self-identifying as a specialist. Here in the middle, you see a rheumatology nurse practitioner who calls herself a rheumatologist. And she states on her website that she's really feels credentialed to do that because she's taken a number of courses from the American College of Rheumatology. Now, as a family physician, I could never call myself a rheumatologist. I'd have to complete a rheumatology residency program and fellowship. So yet a nurse practitioner can self-identify without any repercussions. Here's just a social media posting where a nurse practitioner said, just accepted a job with nephrology and oncology. Anyone have any books they suggest? Can you even imagine becoming, you know, just as a family doctor or an internal medicine doctor, just deciding that one day you were going to open up a nephrology or an oncology practice? It just doesn't make sense. And then here on the right, I show that sometimes nurse practitioners and PAs are being misidentified either intentionally or unintentionally as physicians. This nurse practitioner is being called a psychiatrist, but she's not. And very little is being done to help make it more clear and transparent for the patient. But patients need to know that nurse practitioners are not held to the same standard of care in a malpractice case. That's been upheld in case law numerous times. 1985, Fine versus Permanente, the jury was specifically instructed that a nurse practitioner's standard of care could not be must not be measured by the standard of care for a physician. And then in 2007, a physician was not permitted to testify regarding the standard of care for a nurse practitioner, and that was upheld again in 2015. So it becomes more difficult for patients to receive justice, as many plaintiffs' attorneys won't take these cases because they have to now find a nurse practitioner to testify against another nurse practitioner. It just becomes more difficult. And you know, we really need our nurses. I'm a huge fan of nursing. My parents were both nurses. There's a nursing shortage. We hear all about the physician shortage, but what about the nursing shortage? And when you read about the explanation for why there's a nursing shortage, you'll see things like aging of the population, aging of the nursing workforce. But what is rarely mentioned is the fact that nurse practitioner training has decreased the number of bedside nurses. And a study recently showed they attributed a loss of 80,000 registered nurse positions because of them going into nurse practitioner, provider type of roles rather than bedside nursing. And we need our physicians, we need nurses, and we need doctors. But as I showed you with the graph of nurse practitioner and PA growth, there was a doubling of nurse practitioners, a 60% growth of PAs, and here's the growth of physician graduates. It's really about a 20% increase from 2010 to 2020. It's really relatively flat. And that, although we've had an increase in medical schools, the number of residency spots has remained relatively stagnant due mostly to limitations in funding that have been frozen since 1997. Now, we know that teams work. I support nurse practitioners working in close conjunction with a physician. Studies show that doctors and nurse practitioners working together and physician assistants can provide quality care. But we know that we need a team leader, and that's the person that has the most training and experience. Unfortunately, medical students are getting indoctrinated very early that we're all the same and that no one should really be the leader. Here's an example on the left. A family medicine resident posted that on their psychiatry rotation, they're being supervised by a nurse practitioner. And that's happening in many organizations where instead of being taught by another physician, medical students are being trained by people that really are not their peers, but they're being told that they are. On the right, this was a leaked document from Stanford University from a physician interviewer. This was part of the interview packet in which the physician asked the medical student applicant to how they would respond to a patient who demands the service of a, quote, medical doctor rather than an allied health professional. And the correct answer, according to this, was that the applicant should be able to understand and explain that we're all a team and that in some cases the allied health professional may be able to offer better ways. And basically they were supposed to convince the patient that we're all the same and that the allied health professionals are just as good as doctors. That's what medical schools seem to be looking for in applicants, is this kind of mentality. And frankly, it's not right, and it seems dangerous. And I also question why someone would want to go through the rigors of medical school and residency if we are all the same. Why do some of us need to go through extra training if it doesn't really make a difference? Well, we know logically that it does. Unfortunately, many nurses oppose this, but they're afraid to speak out. I get emails, I get hate mail, of course, like anybody, but I actually get more supportive emails from nurse practitioners and physician assistants than I get negative ones. And it's mostly them telling me, I want to work with a physician, I want to be part of a team, but I'm told that if I speak out that I'm going to get in a lot of trouble, and that's true. This is a slide from the 2019 American Association of Nurse Practitioner meeting. It was the closing ceremony, and nurse practitioner Margaret Fitzgerald was invited to speak. And as part of her closing statement, she put up this slide, which is a smiley face with a zipper for the mouth. And it says, and sometimes the strongest NP voice is silent. And her point was that when nurses speak out against full practice authority, that they're undermining their profession and that what they're doing is wrong and that they need to be quiet. So nurses are afraid to speak out. We just recently had a registered nurse who was attending nurse practitioner school and found that she wasn't being provided the adequate education. She reached out to all the right places to report what was going on at her institution, and she got nowhere. So finally, she came to Physicians for Patient Protection, and she participated in a press conference where she shared her concerns. And she has received all sorts of negative messages, social media posts, personal attacks on her character because she spoke out about her experience. But people that are brave like her can make a difference, and we are seeing more nurses and nursing students who are willing to speak out about this. Doctors are also terrified to speak out, especially when they're employed. Doctors are being fired and replaced by nurse practitioners. It happened in a large health system in Illinois. It happened in Texas. It's very interesting because one of the organizations is called MD Kids, and they fired all the MDs and the DOs. And yet they kept the name because they want to market to the public that you're getting physician-led care, but the reality is that the patient is not receiving a physician. And my friend, Dr. Steve Marin, a very brave pediatrician, who wrote an op-ed, very kind. All it said was that nurse practitioners are wonderful, but they don't receive the same training as physicians. He was immediately fired from the federally qualified health center where he had worked for many years. And this is a headline about his firing. And this has happened to many of my colleagues and people that I know. So most doctors, unless they work for themselves, they're often afraid to speak out. We've only just scratched the surface of this issue. There's so much more to talk about, but you may have questions, and I do invite you to learn more about physician-led care from Physicians for Patient Protection, but also the Association of American Physicians and Surgeons, which is sponsoring tonight's discussion. You know, the AAPS is one of the strongest advocates for the independent physician, and they're one of the organizations that I feel truly has the back of doctors and supports us speaking out about our concerns. And of course, keep an eye out for my book that should be released soon from Universal Publishers. And of course, feel free to reach out to me via my website, RebeccaBernard.com. And I would certainly welcome your questions at this time.
Oh, thank you so much, Dr. Bernard, for that very powerful presentation with just packed with really important information. And we're really looking forward to your book coming out. And so we'll be sure to let everybody know when it's available. And thank you for writing it.
And
Thank you.
I would like to invite Dr. Niran Al-Agba, the co-author, who I notice is on the call. And Niran, would you please say hello to everyone and add a couple of comments?
Yeah. Dr. Al-Agba, if you'd raise your hand if you'd like to jump in here, we'd love to hear from you. So just raise your hand. Oh, there you go. Okay, I'm going to unmute you. You'll see a prompt to agree to being unmuted. That if you'll go ahead and click that. Thanks for joining us, Dr. Al-Agba.
Thanks. I guess I'm just surprised. I didn't expect it. I just sort of wanted to watch my co-author. She did a fantastic job, and I think the research that we've done over the last 2 years to put this book together has really been eye-opening for both of us, and it's amazing how much basically that this whole idea of mid-levels being equal to doctors has been a big propaganda effort on behalf of a lot of organizations. So I'm hoping that our book does do well and gets the message out. Thanks for spotlighting her tonight. I appreciate it.
And thank you. Thank you. And I just have to add my own little story. When I was an attending at Johns Hopkins, one of our nurse anesthetists, Helen, decided to go to medical school. And she used to come back to the OR on breaks and fill in for folks. And we always said, Helen, are you going to become an anesthesiologist? Well, she decided to become a pathologist. And she said, I never knew what I didn't know until I went to medical school.
Yeah, that's exactly what we hear. And in the book, we've interviewed quite a few physicians who were previously nurse practitioners and physician assistants. And that's really what we hear over and over again. It's that they didn't know. No one taught them how to create a proper differential diagnosis. They didn't have the fund of knowledge to be able to, even if they knew how to create a differential diagnosis, they wouldn't have enough knowledge to know what would go in that. So that was sort of a universal statement that we heard from almost every physician we spoke to who was previously a non-physician practitioner.
Well, let's get with the questions here. Dr. Bernard, can you see the questions?
Yeah, I'll help direct traffic here a little
Okay.
bit. We have another,
Okay, great.
we have a number of people with raised hands, so we'll kind of try to alternate between the written, typed in Q&A and then people with raised hands. But one of the first questions that got in here was about the differential in pay between nurse practitioners and doctors. And I know, right, in Medicare, there's different ways to game that system. Like, generally, I think they're paid 85%, but there's the whole, if the doctor bills a different way, then they're paid the same amount. And now, there's even a push for even more pay parity. Let's see, Dr. Bernard, do you have any comments about, the policies regarding the pay differences?
Yeah, I do. So if a nurse practitioner or a PA bills under a physician, then they can actually be paid at 100% rate. If they bill independently that they saw the patient for a separate issue and it was not what they call incident 2,
right,
then they're paid at 85%. It's very confusing. Of course, was it a new problem? Was it a follow-up problem? How much oversight is done? And there's an absolute push right now for pay parity. It's one of the AANP's top goals, and it's already happening in certain states. In the state of Washington and the state of Oregon, nurse practitioners must be paid at the same rate as physicians by insurance companies. And it was part of Trump's executive order as well, was pursuing, well, he asked them to investigate the possibility of pay parity, which is, of course, you would wonder why a patient would want to pay the same amount or an insurance company would want to pay the same amount. I don't know. It doesn't make sense to me. And I did see a second thing on that question, which was about nurse practitioners spending more time with patients and whether that helps with lawsuits. And the answer is absolutely. In fact, I saw, in doing research for this book, I did review quite a few medical malpractice websites, and I found one that was so interesting where they said one of the biggest reasons that nurse practitioners are not sued is because patients like them. They spend more time with them, and that a lot of times they will sue a doctor because they don't feel that we were really listening to them. So I think, and it's one of the points I make in the book, is that as physicians, there's something we can learn from them, which is how to show more empathy, how to prove to the patient that we're more than just intellectual, that we also have the heart of a doctor as well as the brain of a doctor.
Thank you. And let's see, we'll go to Dr. Ritzy here. Dr. Ritzy, I'm going to unmute you, then you'll see a prompt to unmute yourself. Dr. Ritzy, thanks for joining us tonight.
Thank you. Thank you. Great presentation, Doctor. I know Jeremy knows my background, but I worked in family practice for 45 years and did all the routine things from 2,000 babies and delivering and taking care of a lot of those babies. But then I decided to out of my head and was elected to the Oklahoma legislature for 10 years. And I was chairman of the Public Health Committee for several of those years. And every year we had bills brought up to expand the scope of practice, for starting off with the CRNAs and the nurse midwives, and then the nurse practitioners and the PAs. The 2 years after I left, we stopped it every year. We'd have interim studies where we'd speak for a day, and I would have nurse practitioner doctorates come in and brag about their training and so on and so forth. They read the same textbooks, they take the same tests as physicians, and most of the people on the committee were lay people. The rooms in the committee meeting rooms were enlarged and opened up for mostly nurse practitioners to lobby them one-on-one. And I'd always ask some simple questions and state, these are simple questions for maybe first or early med school graduates, and I'm sure you'll be able to answer what are the first signs of a heart attack or most common signs. And they'd always, try to say chest pain and everything. I said, well, American Heart Association says sudden death, and so on and so forth. I just basically lead them into things that they really didn't know what they were talking about, and it changed the committee structure. But 2 years after I left, they just passed the law this year, and signed by the governor, that nurse practitioners now only have to practice in Oklahoma in collaboration. Now, what that means, I don't know, with a physician. My wife's a nurse practitioner, and she realizes that's the worst nightmare that anybody could have, is not practicing with a physician, as she practiced with me all these years. So I think that education is there since Obamacare, and Jeremy remembers in the APS, and we fought it in Oklahoma and outlawed Obamacare by a vote of the people by 68%, but then the Supreme Court trumped us on Article 6 with the supremacy clause and the right to tax you and so on and so forth. What Justice Roberts said, we realize that Obamacare is unconstitutional. Having read the law early on, twice, and my wife read it once, we saw that what the move was going towards is to increase physician extenders. And we saw all the money going into it because the nurse practitioners not only give a lot of money, the pharmaceutical companies give a lot of money to the elected officials to move their bills through the legislature. So I think the biggest thing is awareness, and realize that your book sounds fantastic. I can't wait to read it. But having experienced it for maybe now at least 13 years of seeing what's happening in our communities, that has come to fruition with the diploma mills and the lack of clinical experience. We've seen midwives that have let children die in home deliveries, babies to die, and mothers die in home deliveries. And we've taken that to task, hopefully to bring it to the attention of not only the media, but also the licensing boards. We try to even get the nurse practitioners to be licensed under medical boards. And guess who promoted the expansion this last year? The State Medical Association. They lobbied heavy to get this collaboration passed. So there's a lot of education we've got to do out there. I know a lot of malpractice attorneys. I'm an expert witness with a background in forensic science, and they're just ready and able to file some lawsuits against nurse practitioners. But like you said, they are protected.
Right. Thank you for your comments. I think you hit all the nails on the head there.
Yeah, thank you, Dr. Ritzy. Really appreciate you having you on tonight and sharing that. Okay, let's see here. We have, this is really lots of facets to this topic, and number of questions here. So let's see, here's one. Sorry, the question just, sorry about that. I lost my screen there for a second. Okay, so this is an interesting question, I thought. Thank you, Dr. Bernard. I'm a correctional psychiatrist, and where I work, the title of doctor is used liberally by all sorts of clinicians. Psychologist, chiropractor, DNP, physician can all walk into the room and start with, hello, I am Dr. So-and-so. For some time, I have wondered if the patient inmate is giving informed consent when it is assumed they verbally agree to be treated. Would you comment on the consent giving process? I guess, do patients even know, are they consenting? Do they know enough to consent?
I'd love to. I mean, the corrections department is one of the places that we see the biggest problems with this. And there was actually a report in California produced by Dr. Golding, where he blew the whistle on patients, inmates being treated by psychologists, by social workers, even by students, and who were actually overriding psychiatrist orders. I mean, it was just crazy, and that's going through the court system now. But yeah, the question, I think, not only in corrections, but in hospitals, think of how many people walk into a patient's bedside wearing a white coat these days. And what we're seeing is a trend where people's badge may even just have their first name. It may not even have their title. So I think this is something that we need to make mandatory, that we have transparency regarding clinicians. What are you? Are you a medical doctor? Are you a nurse? Are you a physical therapist? It needs to be clear. One of the parts of my book at the end that we have is a sample informed consent that physicians could use, but also that patients could use, where they state that they do not consent to receive care from a non-physician practitioner. And so I think informed consent is critical, and patients need to have that right.
Thank you. All right, let's see. We'll go to another raised hand here. Dr. Horsley, I'm going to click unmute, and then you'll have to do the same on your end. Dr. Horsley, please go ahead.
Yes, thank you. I'm a physician, an OBGYN physician in New Hampshire, and I was interested in what you were talking about as far as pay parity. I've hired midwives, and I've also been a referral physician for midwives. And Where we are, the midwives that practice independently, which they're allowed to do, actually can make more money than I can make. They take the low risk patients. They have a fee for the patient care. They deliver in a birthing center, so they get the facility fee, and they don't pay $60,000 in malpractice for their patients. So in actuality, I would probably make more money if I left my hospital-based OBGYN practice and practiced as a nurse midwife in my state. It's also been shown that there's at least a 7-fold increase in fetal deaths and newborn deaths with home deliveries, and these are planned ones. So it's certainly not safer. And there isn't much one can do as a physician because they have all of their own licensing boards. They are not under the medical license. So I'm not sure what one can do other than spread the news. And that's, you know, most patients, even when I've had patients I work with, nurse practitioners, they think the nurse practitioner is a doctor. Everybody, oh, my doctor so-and-so. I say, no, that's not a doctor, that's a nurse. And people, the patients do not know. They just don't know.
That's exactly right. And I think it's so important, and this is why we must not be afraid to speak out and just let the patients know. I have several colleagues that are specialists, and they actually created a handout and a poster that they put up in their office where it says, know your practitioner or know your clinician. And it shows, just like I showed, the breakdown between how many years of training and how many hours of training. You know, every time we get an opportunity to share this information with patients, it may eventually begin to make an impact. You know, we know these other organizations have powerful public relations. Our organizations, because they have so many things to attend to, whereas nurse practitioners are very laser focused on this. You know, our organizations, I don't think, have been as effective in, or maybe didn't feel like we need to get the word out about what we do. But I think the time has come, and we really have to make a concerted effort to educate our patients.
Yeah, thank you, Dr. Bernard. And that goes to a couple of questions here we have typed in. Physicians are wondering, how do they have this conversation with their patients? One of the doctors here says she, her patients that go to the hospital now see hospitalist nurse practitioners and not a doctor. And so, she doesn't send patients to that hospital anymore. And then, another doctor is also asking, for some pointers on how they explain this difference to their patients. And maybe your book is going to be one of those tools. I think it's going to be a patient-friendly book too. It's not just written for physicians.
Yeah, we hope so. I mean, that's one of the main goals. It's a very delicate subject because, we know that if we attack the subject too aggressively, we're going to be accused of promoting a turf war, or, that'll create a negative impression. So for me personally, when I talk to my patients, I try to, keep it as positive as possible and just very fact-based. In my personal practice, if I have a specialist that is having my patients seen by a nurse practitioner exclusively, I'm not going to refer to that person. I am certainly fine for follow-up of problems, but if I can find a practice that is physician only, I refer to them exclusively, and I let them know that that's why I'm doing it, because I want to encourage that. Anytime I see misinformation, where if I go on a website and I see providers or something that doesn't seem right, I try my best to let someone in charge know so that they can make those corrections. Sometimes it feels kind of futile, but I feel like every little thing that we can do can eventually make a difference. So I just think it's one-on-one discussions, speaking out whenever you can, although it's difficult, but doing your best just to talk about it being a patient safety issue and talk about it being really about truth and transparency and patients being able to make the best choice for themselves and have the proper information.
Thank you, Dr. Bernard. Okay, we'll go to another raised hand here. Dr. Wax, I'm going to unmute you, then you'll have to unmute yourself as well. Dr. Wax, welcome.
Thanks, Jeremy. Excellent job on the tech and organization of the organization. Thanks, Dr. Bernard, for a terrific review of history and comparison and contrast of the different degrees and what they mean, and getting this information out there. And thanks to you and Dr. Al Agba for writing this book, because it's important to be able to show somebody something, in addition to talking to all of our patients, that we can all help, I mean, for lack of a better word, advertise for the book. I actually worked 20 years ago when I was starting my practice part-time in a federally qualified healthcare center, and I could probably write a book about that. But having said that, there was a nurse practitioner, it was very nice, who was working in another room, and she said, "Can you come look at this pediatric rash?" So I came with her and I took a look, and we stepped out of the room to discuss it. And I said, you know, pediatric rashes are difficult. I mean, being a family physician and having had training in pediatrics and dermatology and all, you know, it's always hard, and it's always a new experience. And she said, well, I super appreciate it, because we never had a dermatology course. And at that point, my jaw hit the floor mentally, and I couldn't figure out how someone could get a prescription pad if they'd never had a course on how to look at the largest, most obvious system in the body. So you don't know what you don't know.
Right. It's so frightening to think of the gaps in care. And I think that's why we see the many referrals, or kind of a ping pong of patients. Well, I don't know skin, so I'll send to a dermatologist. I don't know diabetes, I'll send to an endo. You know, I find it, you know, hurtful and insulting as a family physician, a primary care doctor, when I'm told, well, that's okay, nurse practitioners can just do primary care. Primary care is freaking hard to do well. So it's really it's something that I know that none of the specialists listening to this would ever say such a thing, but we do hear that sometimes, and I don't think that it's fair at all.
Thank you again.
All right. Thank you, Dr. Wax. Okay. Yeah, let's, we have several more questions here in the Q&A box about malpractice issues, liability for nurse practitioners. One, what is your prediction on NP professional liability insurance premiums? And then someone else also is wondering if there's any difference between how NPs are held to liability issues for NPs in states with full practice authority and NPs in states where supervision is required. Any feedback on those questions, Dr. Bernard?
Yeah, I mean, we have seen that malpractice rates are rising. Traditionally, the rates have been extremely low for non-physician practitioners. They are starting to creep up, really simply because payouts are increasing. And I mean, insurance companies aren't dumb. They're going to figure out pretty quickly, as there are more malpractice cases, the rates will rise. And, you know, sometimes I talk to my colleagues and we say, you know, maybe this is just the pendulum is going to swing. It's just going to take time, and we just let it happen. You know, sometimes we feel the sense of futility. Well, let them mess up and get sued. But then you can't do that, because you care about patients and you don't want people to get hurt and suffer and die unnecessarily. But I believe that malpractice rates will certainly go up, especially in independent practice areas. And I think we're seeing that already.
Thank you, Dr. Bernard. Okay, let's see. Let's go to Dr. Wubker. Please apologize if I'm mispronouncing your name, and please correct us. So I'm going to unmute you, then you'll have to unmute yourself. Dr. Wubker, welcome. Dr. Wubker, are you there? You should see a note on your screen asking you to unmute. All right. We will come back to you momentarily. Let's try Dr. Kamen's end. Dr. Kamen's end, please click unmute on your end and then go ahead. Dr. Kamen's end, are you there? Okay, all right, well, it's third time's a charm here. Let's try Dr. Corrigan, another OBGYN who's on with us. Dr. Corrigan, welcome.
Yay, I did it.
Yes, all right, third time's a charm.
I found the unmute button. I'm so happy.
Thank you.
I'm proud of myself. Dr. Singleton, it was so good to see you. You're so amazing. As a past president, it was just fantastic to see you. I cannot compliment Dr. Bernard and Dr. Al Agba highly enough. I've seen Dr. Al Agba's writings before, articles, and Dr. Bernard. I follow your group on social media, the Physicians for Patient Protection. I would advise that everybody check them out. And as usual, Jeremy, there's the AAPS right there up front advocating for us physicians on an issue that is so vital. I have to say this. I don't know if you guys know, but the president and CEO of the National Residency Matching Program, the NRMP, that we all had to go through to get our residency spot, is a nurse. So the president and CEO of that organization is a nurse who also has a DHSC degree, which is a Doctor of Health Sciences, which is a 100% online degree, 70 in front of your name. It's like, you know, some of these degrees, can you guys still hear me?
Yes.
Yeah,
Great,
we lost you
some of
briefly.
these degrees, guys, you know what? It's like, you know, if you want to be a minister, you can go online and you know, be a minister. I jokingly did that, you know, to do sports tailgate marriages, you know. But what I want to say is that, you know, to have the NRMP CEO be a nurse, I mean, nothing against this person, but, you know, where are our organizations advocating for us and saying no? That's why we have a flat line. I mean, what did you show? You showed a flat line, you know, of no increase in resident physicians. And if you have a nurse at the head, it might not be something that occurs to them. And just regarding, you know, this talk regarding midwives, you know, managing things. I mean, I've been there. Let me tell you what, I have very much been there when a train wreck walks in. You know, we've all been there when train wrecks walk in. And I want to say that, you know, after these persons are practicing on their own, you know, and they walk in and you happen to be the physician there covering, you know, and you get handed that stick of dynamite, it's almost like we should have a Good Samaritan clause, you know, to protect us, because for God's sakes, you know, they put out a lawsuit and it's a fishnet. Everybody gets dragged in the lawsuit, you know, and we're the top of the food chain still. And, you know, so we're going to pay ultimately, you know, for this practicing on their own, you know. And just one more thing about referrals, you know, I've heard talk where, you know, they are encouraged as well, again, to refer amongst themselves, you know, to get more practice, you know, and an expertise or whatever, whereas we refer to, you know, true experts. But I want to thank you very much for having this discussion.
Thank you so much for calling, and thank you for that information, because that's a new one for me. I thought I'd researched as much as I possibly could, but I did not know that a nurse was in charge of the NRMP. So thank you for that info, and thanks so much for being part of Physicians for Patient Protection as well.
Yes, thank you, Dr. Corrigan, for raising those points, and you know, that kind of transitions to another question we had in the chat room related to the NRMP. The question was about what is an assistant physician? That sounds an awful lot like physician assistant, but what's a assistant physician? Well, that's a type of license for medical school graduates who did not receive a residency slot. Dr. Bernard, do you have any comments about that?
Yeah, I know a bit about the designation, which not too many states are licensing it, but this is for a graduate medical student that did not match into residency, but allows them to get some clinical training and you know, work in a health profession, because some physicians that are graduated from medical school but did not match, they're being forced to get jobs as, you know, waiting tables or working in a retail office while they wait a year to try to match. So this assistant physician designation would give them, it's usually only meant to be a short stopgap of about a year until they can find a residency spot, and hopefully it gives them some experience and allows them to network so that they can match into a residency. So it's something that some other states have talked about doing. It hasn't gained a lot of traction, I think in part because not all physicians are on board with the idea. They kind of fear that it could be something that would go into a whole separate type of medicine, and that, you know, of course, doctors believe we should all complete our residency. But I think there's a role for it. I mean, ideally, in an ideal world, we would have more residency program slots so that there wouldn't be all these unmatched graduates. But I think that having the assistant physician position, you know, may be an opportunity for some doctors.
Yeah, thank you, Dr. Bernard. And yeah, I mean, we've been advocating for more flexibility in that regard, and we like the idea of more residency slots too, kind of breaking the hold the ACGME has on those. But you know, we advocated for an assistant physician bill in Arizona earlier this year, and two groups came out to oppose it in full force. The nurse practitioners came out to oppose it, and also the Arizona Medical Association. But we're going to keep trying to help those medical school graduates who have significantly more hours of training than nurse practitioners who are allowed
Absolutely.
to practice independently. Okay, let's see here. Let's go to, so there was another Q&A that I think we can handle quickly here. Do you know of any proposed legislation related to truth in advertising? I know there was one, there's one called the Truth in Health Marketing Act that's been introduced the last couple of years.
That's the one I know about by Representative Dr. Bouchon. And really it got sent to some committee and it just sort of, I guess, died, and it hasn't moved at all. I actually was on a call with, I forget his name, but another representative from Texas who's a physician who's running for re-election. And I specifically asked him if that was something that they could try to move forward. And I didn't really get a commitment on that, but I think that's what we need. We need to insist that truth is given to patients, and they have the right to know who's taking care of them.
Right. Thank you. Okay, let's see. Let's go to Dr. Yoder here with a hand raised. I'm going to unmute you, and please then unmute yourself. Dr. Yoder. There you go.
Can you hear me all right?
Yes, yes, please go ahead. So let's see, we heard you and now we don't.
You can hear me?
You're cutting in and out there. I think your
Yes,
internet.
I'm a board certified internist I'm sorry. Are you still there? I don't know how to
Yes, yep, yeah.
my reception anymore.
Yep, well, let's see, you're coming in and out, but give it a shot. See, try speaking again, please. Okay, I think we're gonna.
I'm talking about, like, I guess this is just a question. Still there?
Yeah, you're cutting in and out. So yeah, keep talking. We'll give you another chance here.
You.
We'll give you one more shot, and then we may have to call it quits on. Maybe you have to type it in. Yeah, I don't, Dr. Yoder, sorry,
Right.
I don't think that's going to work.
I'm talking about just a sense of pride.
Okay. Dr. Yoder, we're going to have to, that's not going to work, I don't think. So if you could just type your question and we'll try to get to it. Sorry about that. All right, let's try Dr. Kamenzen one more time here. Dr. Kamenzen, are you there? All right. Okay. Nope. So we're really closing in on the top of the hour here. So I think we should go ahead and start to wrap up. Dr. Bernard, thank you again. Did you have any closing comments you wanted to make before we
I
call
just
it
saw
here?
a few questions where there was asking if anyone could have these slides and have this presentation. Yeah. And from my perspective, absolutely. Yeah. Of course, it's up to the AAPS how they would like to share the information, but absolutely, I'm happy to share any of this content. And also, if you need more resources, because this is something that you want to take to your hospital administration or to your medical society, you know, feel free to reach out to me, and I'd be happy to connect you with some resources and try to help in any way possible so that we can continue this dialogue and get the word out to patients.
Yeah, thank you, Dr. Bernard. Yeah, I just reiterate that the physiciansforpatientprotection.org website has some amazing resources, and I refer to it when I'm looking for information on this. And when we're talking to legislators, we also send them there because it has such great information. So thank you for putting that together. Yeah, Dr. Singleton, did you have any comments you'd like to make before we wrap up?
Yes, I want to thank Dr. Bernard. I read her book cover to cover. And, you know, you hate to say this about kind of a medical scientific book, but you can't put it down. So I really hope that everyone reads it. There's a lot of information and charts and things that you can use to bolster your argument. So when people try to say you're just jealous of nurses or you hate nurses or, you know, one of these things, there's actual numbers about patient safety that we as physicians, that's our duty to make sure that we do the best thing possible for our patients.
Very good point. And thank you, Dr. Singleton, for helping us out tonight. It was a great treat to have you with us. Special treat. So thank you. And Dr. Bernard, thank you again. Dr. Bernard, if you would shoot me your slides, I can make them into a PDF and then share them with people who'd like it.
Yes.
So thank you. And then I just have a few quick closing comments. Right, in about 30 minutes, you'll get a wrap-up email, a follow-up email, and in there, one of the important things will be the link to the evaluation and the link to the post-event evaluation, which you'll need to fill out to get your CME credit. And another quick couple announcements. We will have another webinar in 2 weeks, and it will be focusing on the safety of drugs we're importing. We had Rosemary Gibson talk about that about a month ago, but we're going to have a follow-up to that with some new important information you won't want to miss. So stay tuned for an announcement there. And finally, the last point is on October 3rd, we'll be having our annual meeting. And this year it's going to be virtual, but it's going to be an event you won't want to miss. And it will also be our election. So we will have registration available for that starting right after Labor Day. So midweek next week, we'll have a link going out to register for our annual meeting on October 3rd. And so that's all I have to say. And again, thank you, Dr. Bernard. Thank you, Dr. Singleton. Thank you to everybody who attended tonight and had all the great discussion and questions. And with that, we'll call it a night. Thank you. Good night.
Thank you.
Bye, everybody.
Bye.